everyone, and welcome to the webinar, Bleeding Disorders in COVID-19. My name is Glenn Pierce, and on the next slide, I'm here with our faculty, which includes Magdy El Ekiaby from Egypt, Radoslaw Kaczmarek from Indianapolis, Indiana, Cedric Hermans from Brussels, Belgium, Flora Peyvandi from Milan, Italy, and together with our staff at WFH who have put this webinar together, Donna Coffin and Mace. And so as a result, we're going to be able to do a virtual webinar that will discuss some of the latest information on COVID-19 and bleeding disorders. And then on the next slide, we will be able to take questions at the end. We have a number of different questions that have already come in, and then there is the ability to ask questions that I'll show you in a moment. We'll start with going through the facts and risks to persons with bleeding disorders, the clinical picture from the front lines where Flora has been over the past few months, preparations in countries like Egypt that haven't been hard hit at this point with the infection. And then our question and answer period where we'll be joined by Radoslaw and Cedric. Next slide. We've already issued communiques which are present on the website, and we will continue to update those. This webinar is a bit of an update on two of the communiques, the practical recommendations and the specific risks to bleeding disorders. And then I'll also touch on what's happening in the humanitarian aid program. And we are keeping statements from all of the companies also on the website. And those are being continually updated as well. Next. This is how questions are answered, or asked, I should say. I'll be talking about that in just a moment. Well, here it is. And so, sorry, Mace. Let's start with this one. We have two webinars that are ongoing simultaneously right now, ours and the ISTH webinar, which is focused primarily on coagulopathy in COVID-19. Both organizations do a lot of collaborative work together. We miscommunicated a bit on this one, and it turns out they're both at exactly the same time. However, both are being recorded, and we have both committed to not do this again. Next slide. This is how one asks questions, and Mace will be collecting the questions, and we can deal with those toward the end. And if anyone's interested, I think that we can all stay over the hour if the questions haven't yet all been answered. Next. So I'll start with talking about the facts and the risks to persons with bleeding disorders. Next slide. And so what do we know at this point? It's very fast moving. The information changes weekly, sometimes daily. But this is only 4 months old. It originated either through bats or pangolins or both in the Wuhan area of China back in December. This virus is closely related to SARS, which is now called SARS CoV-1, and the Middle Eastern respiratory virus, MERS, both of which occurred as epidemics in the early part of this century. And it's also related to a number of other coronaviruses that typically cause the cold and flu globally. The symptoms appear 2 to 14 days post-exposure, and we'll talk about this more, but at least 20% are probably asymptomatic, but infectious. The statistics break down something like 80% recover without treatment, although they may be very sick at home. 20% or so get hospitalized, 5% do end up with a ventilator in the ICU, and then somewhere around 2% die. The symptoms The symptoms include high fever, tiredness, a dry cough, difficulty breathing, but the symptoms vary considerably between people, and there's nothing specifically pathognomonic about it. Next slide. This gives us a little bit of a snapshot from the last couple of days, and I just want to point out a couple of things. One is the slide on the left, the graph on the left is a logarithmic scale, and you can see that it is shooting upward for most of the countries, although China appears to have leveled off at this point. But the other countries are continuing to rise, although the curves are starting to flatten out, meaning the acceleration is decreasing. If we look at the graph on the right, this is an arithmetic scale, and we can see that on the arithmetic scale, it's just shooting straight up. As of yesterday, we had about 1.5 million cases. That is, of course, a gross underestimate since we don't have as much testing as is required. And the number of deaths has been up to 88,000 and is continuing to rise rapidly. Next slide. What about practical recommendations for people with hemophilia and other bleeding disorders? Well, the bottom line here is that if you're currently being treated with a licensed product, you should continue to maintain that treatment regimen. There's no reason to fear a shortage or an interruption in the supply chain. It's important to stay in close contact between the HTC and the patients and keep track of stock and keep some extra doses if possible. The goal here is to minimize visits to the hospital or the hemophilia treatment center as much as possible. Next slide. Now, if you're treated with plasma-derived factor VIII or factor IX or von Willebrand factor, the situation may be a little bit different down the road. First, one of the most important things to remember is that SARS CoV-2 is like all the other coronaviruses, lipid envelope. It's like HIV, HCV, HBV, and that means that with the elimination procedures employed, it's destroyed instantaneously during the production process, if it's present at all. And so there have been no supply disruptions according to the manufacturers at this point. But what is important to recognize is that there's been a large decrease in plasma collections during this period that may continue. And so there may be delays, or there may be some shortages 6 to 9 months from now. Manufacturers are doing everything possible to avoid that, but it's important that all of us in the community recognize that the need is very high for continued plasma donations as well as blood donations in your local communities. And that will ensure that we have a supply at the end of the year as well. If blood products aren't virally inactivated, such as cryoprecipitate or platelets, then a risk-benefit ratio needs to be evaluated. There have been no transmissions that I'm aware of at this point from any blood-derived product. However, there is the possibility, and that's shown on the next slide. This came out about a week ago, last week Friday, from the Centers for Disease Control in the United States, their journal, Emerging Infectious Diseases. And in 4 blood donors in Wuhan, they did detect coronavirus 2 RNA. Those individuals were asymptomatic at the time of blood donation. They were not able to trace active infection to any of the people that received their materials, but it does demonstrate that there may be a viremic phase, and this is something, of course, that's going to require much more investigation. Next slide. Now, if patients are in clinical trials, or if your hemophilia treatment center is running clinical trials, then it's all the more important to stay in close touch between the patients and the HTC. To the extent possible, doing remote follow-up visits is strongly encouraged. And if on a gene therapy trial, making sure that liver function testing is able to continue is also very important. It's important not to discontinue or switch treatment if you're receiving a clinical trial drug unless the study team makes that recommendation. If a trial is being planned, postponement should definitely be considered. And as I think you all know, many medical centers have stopped initiation of any new clinical trials so as to not divert resources that are needed to manage the pandemic. It's also equally important for sponsors to be in close, constant communication with the clinical sites where the patients are on clinical trials and track any adverse events that may arise in conjunction with a COVID-19 infection. Next slide. What about specific measures for us to all reduce exposure? Well, it's important to point out that the people at greatest risk for severe disease are those with comorbidities. That includes cardiovascular disease, hypertension, obesity, diabetes, HIV, and older age groups as well as those on steroids or other immunosuppressants. And Flora will talk more about the comorbidities in her talk. The goal here really is to avoid exposure to everyone, or if exposed, to make sure that you're exposed while you're protected. And that includes exposure to lower risk individuals and children who have a greater proportion of people who are relatively asymptomatic, but yet may be infectious. And so that's the single most important precaution. Sheltering in place, social distancing are key tools. Proportion of patients who are infectious but asymptomatic is uncertain, but it's a significant number that can transmit the disease. And that's part of the problem with this particular coronavirus. In a closed space, masks are essential. We could do a whole seminar on masks, but suffice to say, we've got some websites here that would give more information. The N95 mask and the Chinese-made KN95 mask are the greatest protection, greatest barrier, followed by surgical masks, followed by cloth masks. But even cloth masks, if they're properly made, can be very protective to individuals. And these instructions for making them are at the bottom of the page. As I mentioned before, minimizing visits to hospitals is also important. Acetaminophen, paracetamol is the major drug that will manage fevers in patients with COVID-19 and has been and continues to be recommended for persons with bleeding disorders. And then the usual safeguards such as hand washing, do not touch your face, don't aerosolize your cough, and maintaining distance along with the masks are key. Next slide, please. So if hospitalized, the most important thing that can occur is to have a good liaison with the hemophilia treatment center if a patient is hospitalized in a hospital that the treatment center is not at. Treatment center needs to make sure that replacement therapy, adequate amounts of replacement therapy are available, inform the team if the patient is taking emicizumab. We could do a whole seminar on the risk of misinterpretation of hemostasis lab tests with emicizumab, but Roche has done a nice job of broadcasting that, and so that's going to be very important if a patient winds up at a hospital and they don't understand. Inform the treatment center and through the treatment center, inform the new hospital if you're part of an ongoing experimental treatment, especially with balancing agents such as anti-TFPI and fitusiran. And that's going to be very important to have the HTC involved in the management of that patient together with the sponsor of those studies. And then it may require increased amounts of clotting factor levels, increased prophylaxis in a severe hospitalized COVID-19 patient, and that's going to be important to be aware of. Next slide, please. So what about the risks of acquisition? I know a number of people have asked in the questions that we've received if there's an increased susceptibility. No, there's not an increased susceptibility to infection in immunocompetent people with bleeding disorders. It's passed primarily through droplets in the air coming from infected people and from fomites, objects. The question of aerosolization is still an open one. Those are droplets, or those are aerosolization. Aerosols are much, much smaller than droplets, but they can also be effectively stopped by masks. If a patient has HIV, there has not been much information given on that, but if a patient's not well managed, then that would certainly be something to be aware of and to take into consideration in the management of the patient. Next slide, please. What about the risks of infection with a bleeding disorder? Well, we've talked a little bit about the increased risk to patients once they're infected. Flora will speak more to that. But one important point to make is that D-dimers are elevated in many individuals who are hospitalized. The pathologic basis for this is not clear, but it is a prelude if infection progresses to disseminated intravascular coagulation, DIC, which is associated with an extremely high mortality. And so the coagulation system is activated in severe disease. It's part of a host inflammatory response to contain the disease, and is also a part of an ARDS-like syndrome as well. So close monitoring, especially for individuals with bleeding disorders, is really required. And if individuals are receiving anticoagulants, then it's going to be very important that it's accompanied by factor replacement therapy. Next slide, please. There are two articles that appeared in the JTH that I've highlighted here, both from Tang from Wuhan, that give the initial association with D-dimers and fibrin degradation products, and then demonstrate that low molecular weight heparin appears associated with a better prognosis. And we will continue to see more articles that I think will more robustly describe the situation and the potential treatments. Next slide. What about the non-factor replacement therapies? So these include emicizumab as well as investigational agents. It's going to be very important to continue to monitor patients because we just don't know. We've not encountered situations like this where the coagulation system gets activated, the patient has a systemic infection with multiple organ systems that are being damaged. And so it's going to be key for the Hemophilia Treatment Center to stay in touch with the hospital that the patient is in, and stay in touch with the manufacturers of these products as well to get a better understanding of how to best manage the patient. Next slide, please. So I've mentioned before, bleeding disorders are not comorbidities. This is something that Cedric has emphasized, and we've placed into an editorial that is just being published by Hemophilia. And there's been a question that should it be considered a comorbidity, and we should be very proactive in emphasizing that having hemophilia or other bleeding disorders should not exclude individuals from any invasive management that would be required for COVID-19. Something to be aware of if rationing occurs. Next slide, please. I want to touch on the humanitarian aid program. This is run through the WFH offices by our medical director, Asad Hafar, and we have had significant problems and have taken some immediate steps at the beginning of this week to try to address those. Airports in a number of the countries that we ship to, which is between 60 and 70 countries, have closed their airports, not just to passengers, but to cargo as well. So we've got a number of disrupted supply lines that are challenging for countries that we were about to send donations to. And so we're asking countries to keep a close eye on their existing stock and unfortunately to stop any immune tolerance induction therapies, to stop elective surgeries, and depending upon their supply, to stop prophylaxis for any adults and children until further notice in order to preserve stock for emergency use to treat bleeding episodes. And then where we can, we are shipping donations to countries that we can get into to continue to build and maintain their stocks during this period of time. And we've placed something on our website regarding that, and we'll continue to update that. Next slide, please. So the key thing here, the bottom line, avoid this infection if at all possible. Maintain hygienic protocols. Use gloves, face masks. And for our healthcare providers who are on the front lines, we thank you very much and ask you to continue to be as careful as possible. With that, next slide. I'd like to turn it over to Flora, who will talk about our next section. Flora?
Thank you very much, Glenn, and good morning, good afternoon, good evening to all of you all over the world. What I'm trying to report today is my personal experience, mainly in Milan, in Polyclinic of Milan and University of Milan, and my team, and actually with a limited number of the reported data from all other groups around the world. Next slide, please. So during my call, I will touch the transmission and clinical presentation in the patients, the diagnosis, and where we are standing with the treatment and what we know. Next. So as we know, everything started for us in December 2019 when the Chinese scientists identified a novel coronavirus as the main causative agent for this acute respiratory syndrome in Wuhan. And this rapidly spread, and I remember when we were hearing the news from the TV in Milan, we couldn't really imagine how fast this could spread all over as an epidemic disorder around the world. From China, I would say. And it was in February 2020 that WHO designed this disease as a coronavirus disease 2019, which called now COVID-19. And in March 2020, 1 month later, it was announced by WHO COVID-19 outbreak like a pandemic. Next one. So now where we are standing is really very difficult because as Glenn was mentioning, our understanding of COVID is changing, is evolving, and what I'm reporting today might not be true in 1 week time and is completely different to what I was believing 1 month ago. So please accept my apologies if everything that you are hearing from the media or the reports are not reported during my presentation. Next. So let's about the epidemiology. We know now that globally more than 1 million, as we heard, of cases of COVID has been reported. And the numbers are even more than that because we did not have the facility to map and with a high density to map all population that are affected. So the numbers are definitely underestimated all over the world. And this is no doubt representing a global public health concern, and WHO is declaring an emergent situation that needs further attention of all of us as a health system. So special attention is also needed for protecting and reducing transmission based on what I was saying, because that would have an important role in the transmission if we not map and clearly understanding the susceptible population and those that they are doubtful for the transmission. And next slide just is reporting what I was just mentioning before. More than 1.5 million of the people around the world is affected, and of those, about 655,000 are located in Europe and 384,000 in the US, and a part of China. Fortunately, the rest of the world are facing less with this problem. And of course, the density of the population are not similar, and that's a very important issue, needs to be understood in the future, whether there is a different strain of the virus or any environmental issue could have a role in the dissemination of the disease. And next slide, just showing you what is and what was about 2 weeks ago when we did touch, unfortunately, the number of deaths over 10,000 in Milan, which now is over 17,000. And as you can see, with the isolation in the roads, this is Milan, very busy city, and I never seen in my life something like that. That's the only method that could help us right now to touch a lower number in the last 2-3 days. And next slide are the data that we have about the transmission, and that was what Glenn was reporting. So the main transmission is by person to person and through the droplet and the close contact. And that's the reason why you have to wash your hand and you have to be careful about not touching the people who could be affected. But we don't have to forget that the transmission of COVID could also occur with asymptomatic individuals. And this is what we call it the gray area. And these are those individuals that are within the incubation period and they do not know to be affected, and they could make a transmission of the disease. And the incubation period for the COVID is thought to be between 5 to 14 days. However, there are some data mentioning over 25 days. And this is the period that you have to keep in mind. And as you can see in my next slide, here is very clear, more or less, that about 80 to 85% of the people could remain completely asymptomatic. About 30% are not having any symptoms, and about 55% they have only mild and moderate symptoms. And these are the most important group. How we are going to identify them, how we are going to map them, and how we are going to quarantine them, because these would be the biggest vector for the dissemination. And it's all over the population, there are 10% almost that they are having the severe symptoms, and the critical ones are about 2 to 5%. Again, our data in Milan was different. If you look, for example, our mortality was very high because probably we were testing less people, and that was not a real denominator number, and our mortality probably is standing over 2 to 3%, but the density of the population and the mapping was not really well done at the beginning, and that's a reason why we are underestimating the numbers. So about the contagious, you can see still here that 5 to 14 days, and in some of the data for the mild moderate could remain up to 21 days, as I was mentioning before. Next slide is reporting what are the clinical presentation. The most severe one are coming with pneumonia, and some of the people, as I said, they could have really little symptoms, but mainly the patients, they have fever, and this fever are a very low amount of fever, cough, dyspnea, and if we look with the X-ray, there is a bilateral infiltration that is the responsible for dyspnea and the cough and the symptoms of this patient. So the case fatality, as I reported, is about 2.3%, and fortunately I have to report that even in our population there was no death among those people, that they were not critical cases and no critical condition associated with the COVID infection. And next slide. is just mentioning what I was trying to report in my previous slide, that a disease could remain very low or could progress and end up with a series of the complication and end with a critically ill patient which need the high intensity cure with the intubation. Unfortunately, that's in very low number of the patients. And next slide are reporting what needs the further investigation and results, because very surprisingly, those people that they have the chronic lung disease, they are not the first people who are the most, I would say, the best candidate for this virus. And cardiovascular disease, particularly diabetes and hypertension, are those comorbidities that seems to be very much associated in the case of the severe illness with the COVID. And we need to understand what are the common conditions that is so favorable for this virus. Next slide. What about the lab? It's very interesting when, as a physician, you look on the data for the lab, the data are very similar between the patients. However, the severity could be different, but we have almost always lymphopenia, and we have sometimes the elevated ALT and AST, the liver enzyme, and we have some of the clotting factor, as has been mentioned, altered. But mainly, I personally think our experience with more than 500, 600 patients with COVID, we are not believing on DIC in this patient, and we do think that most of the patients, they have a normal level of PT and APTT, a little bit of alteration on the PT, probably related to the damage on the liver side, but there is a high level of fibrinogen and there is a high level of D-dimer. There is extremely high hypercoagulability in this patient, which require really particular attention of the physician and the centers. Next, please. So what type of a specific test needs to be done? This was a big issue for us at the beginning because of the availability of the swab at the beginning and which patient need to be tested. In the US, the CDC recommend the collection of the specimen for the upper respiratory tract, nasopharyngeal or oropharyngeal swab, and the lower respiratory tract by different biological material. So what we do, we make the extraction of the RNA, and with the RT-PCR, we are detecting the virus, and some of the center for the research, they are making the quantitative RNA to understand what is the amount. And there are other type of tests like ELISA assay showing what is the presence of IgG or IgM. But right now, for the diagnosis, the RNA RT-PCR is ongoing. But if initial testing in these patients are negative, but the physician thinks and has the suspicion for the COVID-19, then WHO is recommending resampling and testing for multiple respiratory tract sites. And I think this is a very good recommendation. And negative RT-PCR on the swab, on the biological material, might not be enough. And if we can see that there is the CT finding, which is subjective for the pneumonia, then we have probably to make the retesting and going further for the investigation and making a final diagnosis. And next slide, please. So the test performance at this point is still not 100% clear. It's impossible to sort out the absence of the virus because there is no gold standard. The specificity seems to be high with this RT-PCR, and the sensitivity might not be very high because about 2/3 of the patient could be positive, and 1/3, beside the positive symptoms, they result negative. And a single negative RT-PCR does not exclude the COVID-19, and that's a very important message that you have to keep in mind. And if this is negative, ongoing isolation and resampling should be done. Please pay attention to this last sentence, because we unfortunately did lots of transmission, even in the physician and nurses, because we didn't know this gray area of the patient who were becoming later on positive, but the test was negative, and you have to make the isolation as soon as possible. Next one, please. So this was the strategy that we had in Polyclinic of Milan. We had lots of patients in our ER, and we had to make a strategy, and that was for influenza-like illness, no hospitalization suggested by the ER, and the patient were having fever, cough, and some headache. So we were not having enough swab to make all of them, and we didn't do the nasal swab in all of them, and that was the reason why our data was underestimated, and that is the reason most probably because we have a higher number now of the patients, and that's the reason why we are reporting a high mortality, because our denominator might be underestimated. And the severe acute respiratory infection, they were isolated with a nasal swab, and eventually with the acute respiratory syndrome, the patients were isolated and the swab was done, and with the positive result, the admission to the ICU was done. Okay, next slide. And if the first test was negative, we were retesting the patient after 12 or 24 hours. And if it was positive, there was admission. And if it was negative, we was discharging and making admission to the different unit with a different type of intensity, I would say. All right, next slide. So what is the radiological type of investigation? A lot has been done, a lot has been said, but I would say for the facility, especially if there is no so much facility, start with the X-ray is very good. However, the sensitivity might remain about 60%, depends in which stage of the disease you are. For example, for this X-ray that I'm showing, there is no doubt for the physician, this is COVID-19. I think after you see 50 cases, you have no doubt about that. However, in some cases might not be easy, and you do need to go with a further investigation that you can see in my slide. For example, with a CT scan. Can I have the next slide, please? So with a serial CT scan, for example, sometimes in the patient, it's just helping you to understand how the disease is evolving and how after 5 days, 15 days, and 21 days, expansion of bilateral pulmonary lesion is clear in the CT scan. But as I said, it's not easy to do the CT scan in all the patients. And that's the reason why we start with the X-ray and sometimes with the ultrasounds, which is sounds to be very sensitive. And in those patients, there is a doubt about the pulmonary embolism, or there is a doubt about the diagnosis, we go with the CT scan. Next one, please. So the next chapter and last chapter of my talk is on treatment. It took me really very much to understand how I have, or we have to, as a group, to treat our patient. I'm in the internal medicine department, but we were making every day different meetings with the intensive cure and intermediate cure, and trying to understand how to move, because this is the issue. The patient is coming to the ER, but the stability of the patient is not always the same, and they're moving from one ward to the other one based on the intensity of the patient. So the disease has a distinct phases, and the treatment will differ as patients move through these different phases. And in my next slide, I'm trying to show that basically what you need is the oxygen treatment therapy, and that's the basic, and that's strongly recommended in patients who have the symptom, and when the oxygen saturation for the normal people are lower than 96%, and for those that they have the pulmonary chronic disorder, and they are about 88 to 92%. So you do not need the oxygen therapy if the level is actually over the 93%. And in the next slide, a part of the oxygen therapy, which is done by hood, mask, CPAPs, or in the worst situation with the ventilation. That's the most difficult part, because not every country has enough number of the bed and ventilation for covering all the patients if they're coming at the same time. This was what it was happening, unfortunately, in Milan and Wuhan and those and Spain, and unfortunately also in New York these days. So next slide. I think this is a key slide of my talk. If you see the severity of the illness, you can divide it in 3 stages. The first stage is the early infection, when the patient is starting to have mild symptoms and you might not even to pick the patient, and that's the viral duplication and amplification. And then in the next part, you have pulmonary phase, when there is a shortness of breath, hypoxia is starting, and the chest image is changing, and you could start to have some inflammatory marker is moving. And then the last stage is the hyperinflammation and hypercoagulability of the patient. So it's very important that you make a good selection of the drug. For example, if you start with the corticosteroid treatment in the stage 1, that's really dangerous and is harmful. But if you do it in a stage 2 or a stage 3, when you have the inflammatory situation, that might be extremely useful. Or if you use your antiviral treatment in a stage 3, you might not get any result, because the duplication has already started and you're not going to get any result from that. And in terms of anticoagulant therapy that was clearly reported by Glenn, the heparin level that we were using is not definitely enough, and now there are different clinical trials also in Milan ongoing to understand how we have to make the intensive treatment in order to make the prophylaxis for our patient for venous and arterial thrombosis, and that should start at the earliest stage, and in order to prevent the formation of the clot. And that's again very important if you have a patient with hemophilia that is using some drug that could be more I would say, protected in terms of the bleeding. If they get the COVID infection, you need an expert center to talk to you and understanding how to manage the patient. And next slide. So as the treatment, if I have to conclude, the identification of the novel drug is needed, no doubt. We need vaccines, we need one drug that could solve lots of issues over there. Still is not there, we know that. And the most challenge for us, we have, at this period of time in the last month, was to learn and to treat. And testing the therapies at the same time, making clinical trial and making the biggest, the best choice. And this was the biggest challenge we had to face up with that. And the reason why we thought to make this webinar today, and even this part which was not related only to hemophilia and bleeding disorder, but just explaining where we are standing and what is needed, was just that, and just sharing our conclusion with you. And for the next slide, I think I want to acknowledge all my group. This was the first day, month ago and month and a half ago, when we started the COVID center at Angelo Bianchi Bonomi Hemophilia Center or Polyclinic of Milan. And these are my youngest group. And I want to thank all of them and all my nurses. Without them, we could not really carry on this type of services. And thank you very much for your attention. And I would be happy at the end of the session to get any question. And now I think Magdy is going to bring his talk.
Magdy, you're on mute.
Yeah. Okay. Good morning, good afternoon, and good evening for all those who are attending this webinar. It's really interesting, but COVID-19 has changed it to us, because I can see that more than 1,200 participants from all over the world are attending without the hurdles of travel or visas or borders. So this is a really dramatic change. No matter we are far, we are still close together. So during this presentation, I mean, thanks to Glenn and Flora, they had a very comprehensive coverage of the disease, whether from the pandemic point of view or the clinical management, as Flora has just highlighted. I would cover during my short presentation on what is the situation can be like in developing countries and Egypt, and in a smaller level, the East Mediterranean region. I will give some information. So next slide, please. I will cover during this the situation in Egypt, or the preparedness in Egypt, the impact of the COVID-19 on hemophilia care and the role of the Egyptian Society of Hemophilia, and at the end a few slides about the situation in East Mediterranean region. Next, please. So the Egyptian government started to take actions for containing the COVID-19 beginning from mid-February, when they started to have on the radar the possibility of people coming infected from the borders. So, I mean, questionnaires, data about the foreigners coming to Egypt with their details of accommodation to be followed up together with temperature scanning at the borders was the first step. And then in March, the closure of the universities, schools was started. Mid-March, closure of the airports, and then later, 1 week later, there was a decree for a curfew that's now for almost 3 or 4 weeks. So starting from 7 p.m. to 6 a.m. and then later on yesterday they extended it to become, I mean, shortened it to become starting at 8 p.m. and starting and ending at 6 a.m. Cases that have suspicion, they have a hotline number they can call, and according to the whether it is just an exposure or that they have start to feel some symptoms, they will be asked to isolate themselves at homes and take distances from their close contacts in the home. If they feel that they are not getting better in few days because of the confusion between the early symptoms of COVID-19 and flu-like symptoms, they will call the same hot number, and then they will be asked to come to the hospital where they take care of the COVID-19 patients. If they have the PCR, they will positive, they will be isolated, and then according to the intensity of the disease, they will be managed in a way not too much different from the way Flora described what is happening in Italy. Next, please. So the Ministry of Health issues a daily reporting on the newly diagnosed cases. This, I think, was on the 7th of April. Where still the number of cases diagnosed is low, whether this is due to less testing or whether because of the spread of the virus is still slow in Egypt. But still it's very low compared to other to Europe and the US. The total number is now close to 1,500, and the total number of deaths is about 100. Up to yesterday reporting. Next, please. Also, the Ministry of Health issues like a position of the spread of the virus in Egypt compared to the rest of the world. So they say that we rank like the 55th country on the number of diagnosed cases. Rate of recovery is about 19% up to date, and that the number of deaths in a specific period of time. Next, please. So what about the situation in Egypt? So far, unlucky enough, we have no report of a case of COVID-19 among patients with inherited bleeding disorders. To give you an idea of the kind of care offered, still the standard of care is based on episodic treatment with very limited cohorts on regular prophylaxis. Few patients, I would say less than 10, are on Hemophilia, and we have no patients on gene therapy or other types of clinical trials. Next, please. Regarding the stocks of the clotting factor concentrates, we have a kind of a central procurement system for the clotting factor concentrates. So to my knowledge, there is a good stock in the warehouse of the Ministry of Health, which is used to cover the patients under coverage of health insurance organization. And those who are not covered by health insurance organization, they have a system of partial subsidy through what is called ministerial partial subsidy decrees. And for these people and on the episodic treatment, there is still enough products. Also, we were lucky enough, and thanks to WFH, that we have received early this year a big amount of humanitarian aid donation. I think it was something close to 5 to 6 million units of factor 8 and 9. So we still have also a good stock from the humanitarian aid products. As part of the government measures to reduce the pressure on the health facilities, they gave a decree that patients with chronic disease will receive 3-month supplies of their medications, but yet, unfortunately, for the health insurance organization, they recognize clotting factor concentrates as biological, so they do not dispatch them for home therapy, and still patients need to go to hospitals to receive their clotting factor concentrates. Next, please. So with this situation, the patients with hemophilia really have great concerns to go to hospitals for possible risk of infection with SARS COV-2, and also with the restrictions in the during the curfew times, if they have an acute bleed that needs to go to the hospital. This is also a limiting point. And in addition, what increases the difficulty is that on the radar, or if the COVID-19 spread increases, which we hope that will not happen, but there are certain hospitals that are planned to be converted from regular hospitals to isolation hospitals for COVID-19. And among them, to our information, is like 2 or 3 hospitals from the health insurance organization, which have hemophilia treatment centers. So if these hospitals as well will be closed, so patients who are assigned to go to these hemophilia treatment centers will have also difficulty to access to clotting factor concentrates. For the 2 centers that have regular prophylaxis practice, and since this is not financed from the government, but rather from charity, we are able to dispatch the products for home therapy for the kids on prophylaxis on a monthly basis to reduce the need for them to come to the centers. Next, please. The Egyptian Society of Hemophilia is also doing a lot of efforts in this difficult time of the COVID-19. So, several educational materials about how to protect yourself from COVID-19 or from infection with SARS CoV-2 was posted on the Facebook page and the website of the Egyptian Society of Hemophilia. You can see an example. It is in Arabic on how to protect yourself, what do you do if you have a bleeding, and similar things. Also, the Egyptian Society published the Arabic translation of the World Federation of Hemophilia Humanitarian Aid Guidance document on the website and through social media. For the problem of the patients have to go to their hemophilia treatment centers to get their clotting factor concentrates, the ESH sent a letter to the chair of the health insurance organization, asking him to have an exceptional supply of home therapy with few doses of clotting factor concentrates, and also the active patient groups sent a letter to the Prime Minister asking for the same need to have the concentrates for home therapy. Next, please. Also, the ESH is actively participating in WFH webinars and guidance documents and communicate them with the patients. Many patients also we have these questions: is this, if they like those who will receive platelet transfusion or who have to receive plasma transfusion or blood transfusion, is blood safe enough, and if it can transmit the virus to them. And this is something, I mean, we are following the statement of the WFH, and I think it is the statement of many international organizations that the risk is theoretical or potential, but the decision should be taken by the medical authorities to decide the risk against the benefit. Also, some questions: if the patients develop the SARS CoV-2, the COVID-19, how they can handle if they have a bleed or the clotting factor concentrate administration. And for this purpose, the Egyptian Society of Hemophilia is organizing a coordination with its medical advisory boards, that if we have a report of a patient who developed COVID-19, is to communicate with the treatment hospital or the isolation hospital in order to provide, if there is a necessity, to give some prophylactic clotting factor concentrates to avoid bleeding from the inflammatory process that's happening in the respiratory tract, upper or lower, and if he is already having a bleeding episode that needs to be treated with the clotting factor concentrates, and that the from the humanitarian aid, the society can provide the needed quantities of clotting factor concentrates. Next, please. Also, the ESH provides home therapy to patients in need through humanitarian aid products, and we are discussing with one pharmaceutical company to support shipping these products to the homes of the patients by couriers, and planning for social media activities with focus on management of hemophilia with the current situation on World Hemophilia Day. Next, please. So a few words about the situation in East Mediterranean region. Next, please. This was an article that was issued a few days ago, where the writer is discussing the situation of COVID-19 in the Middle East, and he categorized the levels of containment into according to the regions. So in the Gulf regions, they are very much, in addition to social distancing, is on testing to identify the infected persons, as well as those who are immune. Some countries who only had a very strict measurements on the social distancing, like Egypt, Jordan, and Tunisia. And then we unfortunately also have the areas of conflict like Libya, Syria, and Yemen, and the impact of this conflict and the difficulty, combined difficulty of the conflict and the COVID-19 situation on the, which can have a challenge for the patients with the hemophilia in these countries. And we hope that this will be contained or controlled. The writer here is discussing also what was Flora saying is that the spread of the virus has a different attitude in different regions. So still there is a slow spread of the virus in the region, in the Middle East region, and probably a similar situation is happening in Africa and Latin America. Whether this is due to less capabilities of diagnosis or whether it is because there is a different, because of in these countries, the majority of the population is young age, and so this is a kind of protection against the severe disease, or the warm weather that may be a less favorable environment for the virus. So these things, I think, needs to be studied and see how it can progress. Next slide, please. So this is a sort of communication that we try to run between Rana, myself, and the different societies of hemophilia in the Middle East or East Mediterranean region. So this was an email from Ahmed Abdelaziz from Qatar describing the situation, still under control, very strict measures to control the virus, preparedness for any cases, and very good treatment and very good outcome of the treatment, and no cases of hemophilia or other inherited bleeding disorders have been reported. Next slide, please. Also, because Rana received some complaints from the areas of conflicts, particularly from Syria and Yemen, and in some of them, these countries, they asked also the patients to come to get their treatment from the centers. She communicated with me, and I communicated with the Director of Blood Safety of the World Health Organization East Mediterranean Office, and we asked him if he can send a letter to the Ministries of Health in the region, asking them or advocating with them that they have to give a home therapy with clotting factor concentrates during these difficult times. He already did this. This is the email, and he sent it to the higher management, which addressed this letter to the Ministers of Health in the region. So we hope that the situation will gradually improve in favor of our hemophilia community. Next, please. So this is all. Thank you very much. And of course, any questions, we are staying.
All right, thank you, Magdy. Thank you, Flora. Let's open this up for questions at this point. And I know we received a lot in advance. We also received some through Mace, and then the chat box here is, with questions and answers, has also been overflowing. So we'll start off. I'll sort of triage, if I can, the questions, and we'll be looking for short answers from our panelists because we have a lot of questions to get through. Are people with hemophilia more susceptible to COVID-19 as a high-risk group? I'll take that. No, they're not. It's all about the comorbidities that Flora has already described. Does COVID-19 affect people with hemophilia differently than others? What about those with hepatitis C? Flora, do you want to take that?
Sure. We have a large center with more than 300 severe cases, and until now, as I was saying to my colleagues, we haven't seen any patient with COVID positive. So I wouldn't be worried at this stage, really any association with the patient with hepatitis C or the patient with hemophilia.
Okay, thank you. Cedric, why don't you take the next one? Reported cases of COVID-19 in people with hemophilia.
Sorry, could you repeat it?
Oh, are there any reported cases of COVID-19 positive people with hemophilia and any uncommon symptoms?
Well, there has been one case reported and published. It's available on PubMed in hemophilia this week from China. This is the only reported case so far. In Europe, through the European registration system UHAS, it has been asked to centers to register their case. And in my own center in Brussels, we have had 4 cases so far. 2 patients were found to be positive outside the hospital and did not require to be admitted, and 2 other patients had to be admitted. In fact, I have to emphasize the fact that there was a very good interaction between the patient and the hemophilia team even before their admission, so we knew that they would be admitted. So the liaison was very good, and we could clearly inform the emergency and the other departments how to manage this patient. One of these patients who was in the trial has been discharged. No ICU, no ventilation was needed. Another patient is currently in ICU under ventilation. I have to emphasize the fact that this patient is under continuous infusion of clotting factor concentrate delivered through a central line, aiming at level of approximately 100%. And this patient is receiving the same, and I think this is an important message, this patient is receiving exactly the same kind of care as any other patient. Important to stress the fact that we also monitor the D-dimers, and this patient is even on low molecular weight heparin at increased dose because the D-dimer were so high. So it's a little bit exceptional, but at the same time, we are giving this patient high amounts of factor VIII, but we are also treating him with low molecular weight heparin. We hope that this patient will be able to leave the intensive care. His situation is a little bit dramatic for the moment. So, but he's receiving optimal care for the moment.
Thank you, Cedric. Next slide. People with COVID-19 and hemophilia, probability of internal bleeding. Flora, could you offer a brief answer to this?
So as I said, the association, I haven't seen any association, not with hemophilia, not with bleeding disorder. And UHAS actually now is just trying to collect the data on all hemophilia center in Europe, and we would have more data on that. In terms of the bleeding, it seems that is a higher tendency for clotting, and based on that, I would not be worried about bleeding. And as I said, we have to understand whether those that they have an intensive type of treatment for the higher prophylaxis level, when they get affected with the COVID, what is happening to them. So I would not be worried about the bleeding. And the data on the only data on the bleeding, it was about hemothesis, which was reported in the general population in less than 2% of the general population.
Okay, thank you. The next question really is a local one. How should a patient with a bleed manage the bleed with regard to their treatment center or the emergency room? And so that's why it's important they have contact with the hemophilia treatment center and understand what the protocols are in your particular location. If testing positive, what are the risks of thrombotic complications in a person with hemophilia? I think Flora has already answered that question. Let's move on. Should a person with hemophilia administer factor if testing positive? Yeah, so we've gotten a lot of questions on that. And I think what Flora said was, and what Cedric is actually doing is giving a lot of prophylaxis to maintain high clotting factor levels. With COVID-19, if you have severe disease and you're in the hospital or in the ICU, then you have got a lot of organ damage ongoing. And it's important to maintain hemostasis as best as possible. But as Cedric described in his ICU patient, it gets complicated and requires a lot of intervention on the part of the HTC physicians. We've had a number of questions on emicizumab and similar products. What we've said is that you should maintain your current treatment regimen with all approved products. I don't know if any of the panelists would like to further comment on that.
No, I think it's very important not creating any fears in our population. That's a very important issue. So we do not have any reason until now to think about stopping our treatment. We have to continue whether we are on the regular prophylaxis with any type of the product or any clinical trial. Of course, as I said, for those people that are with those products that giving them a higher state of thrombin generation, if they get COVID infection and they get sick and they get to the hospital, is a job of us and the doctor to think about how to make the balance between the hypercoagulability and the good hemostasis in terms to have no bleeding and no thrombogenicity. But with the people who just even is a positive but has no symptoms, I don't think there is any worry over there.
I think that with Hemlibra, the important thing to emphasize is that it doesn't actually make sense to get off it if somebody thinks about reducing any risk in the short term, because Hemlibra remains in the system for a long time after getting off of it. So if somebody thinks that maybe preemptively I should get off it just in case, it won't really work. And the same goes for other long-lasting therapies such as fitusiran.
Yeah, maybe I agree, but maybe the only things we have to explain to our patients, if you do get COVID and you have the sign and symptom, and if you're ending in a place where there are not hemophilia treatment center, to all physicians, please explain them, asking them, and putting them in contact with your hemophilia center. So there should be the communication between those specialists that are working in the COVID area and your hemophilia treatment center. That's a very important point.
Maybe
some Arabic translation to some guidance for the patients who are using Hemlibra, particularly regarding the laboratory control of hemostasis that may be misleading if the people do not know that this patient is on Hemlibra. So this is also an additional point that has to be communicated if the patient develops the COVID-19.
And maybe, Cedric, here, what's important, can you hear me?
Yes.
Yes, well, I think what's important is to know exactly whether your patient is admitted in ICU. If this is the case, the hemophilia team should know, and you should interact with the ICU team every day, twice a day, and make sure that your patient is receiving the optimal treatment. And you need very good discussion every day how to adapt the treatment, because that becomes really tricky. Even if you are on emicizumab, you don't have an inhibitor, you might need extra factor VIII, you might need low molecular weight heparin. It becomes really, really complex, and you need to balance nearly on a hourly basis the risk of bleeding and the risk of thrombosis. But I think if you do this in close collaboration, you will be successful, but it requires a lot of close collaboration.
We've had a few questions on gene therapy clinical trials and what to do under that circumstances with COVID-19. Cedric, you've enrolled a number of patients in gene therapy trials. Could you make a brief comment?
Well, you know, I think it's not yet in the public domain, but we had one patient. I will not provide details because I'm not allowed to do it, but we had a patient who was cured by gene therapy a few months ago, and he developed COVID, had to be admitted. And I have to say that he had to stay in hospital for 7 days and then left the hospital. So I think it's a very optimistic message. You know, gene therapy did not interfere with his hospital stay, but I have to emphasize that that guy did not need to be admitted in ICU. But we managed him very closely, and gene therapy did not interfere with his management.
The thing to remember about the gene therapy is that if a patient has clotting factor levels that are in the normal range, then I think much of the problem with hemophilia is dealt with. If the patient has suboptimal levels, then like the consideration for emicizumab, where a patient is not restored to normal coagulation, one needs to consider factor replacement therapy as well.
Certainly.
Glenn, if I can add something. I think there are 2 points which we were worried at the beginning of COVID for gene therapy. First was whether the immunosuppressive treatment that some of our patients could interfere and getting worse the clinical situation of our patient. And based on the literature and our personal experience, it doesn't seem to be any association. And in somehow there could be even beneficial effect of the immunosuppression in some stage of the disease. So that worriness, I would say, now is gone. And the second point is the jump of the liver enzyme. And as I said, COVID, as every type of virus, could increase the amount of the enzyme. So even from that point of view, I haven't seen really data worrying me, but that's something we need to keep an eye. And that's the reason why the drug company did, stop the enrollment of the patient, but we are carrying the patient. And of course, we are educating our patient, not coming to the center and trying to give all the services if it's where is needed, but just carry the process of the trial as it was and has been supposed to be.
The one slide you showed, Flora, that showed the damage caused by the virus and then the inflammatory response,
Exactly.
and the damage caused by the inflammatory response, at that point, steroids are being used. I don't think we have any controlled trials.
Exactly.
Steroids have been used in that inflammatory phase with success in a number of other diseases over many years. So
yeah, our personal data are showing when you use the steroid in the inflammatory part is really reducing the mortality of the patients. But yet we have to wait.
yeah, and the next question, in the current situation, should those receiving treatment in the hospital request home treatment if possible? Well, absolutely. There are many places where home treatment is restricted, but we have been advocating, along with a number of other groups, that home treatment is the best way to manage bleeding episodes in hemophilia. Because if you have to go to the hospital, then you're hours away, you've got more blood accumulation in joints and muscles, and more damage ensues. So if any small silver lining can come from this, I would hope that home treatment would be more universally developed and accepted amongst our global community. Next slide. If testing positive, what medicines? Acetaminophen, paracetamol, same thing, are recommended in hemophilia. There have been various rumors going around about ibuprofen. I don't think any of those have been established as true, but individuals with hemophilia shouldn't be taking ibuprofen in the first place. Heparin for treatment, I think that Flora and Cedric have covered that. Chest drains, well, when you're in the ICU, lots of things happen, and that's why, as Cedric pointed out, they're taking patients to 100% factor levels.
Yep.
Yeah, so the same thing for the last question. High doses of factor are required for patients going into the ICU. Next slide, please. Can the virus be transmitted through fresh frozen plasma cryoprecipitate? Well, this is what we talked about at the beginning, and there's no evidence of transmission yet, but there is evidence that RNA for coronavirus 2 has been found in asymptomatic blood donors in Wuhan. So this is a developing story. Stay tuned and follow it. But that involves then, if you're taking cryo or fresh frozen plasma, an assessment of the risk-benefit for that, which includes how much coronavirus 2 is in your community. Will access to plasma products be affected? Magdy, you in Egypt, you use a lot of plasma products. Are you seeing a decrease in donation for cryo, fresh frozen plasma? You're on mute.
Yes, I mean the donation rate is going down, but I mean so far because of the enough stock of the clotting factor concentrates, there is no need to use fresh products so far for patients with hemophilia.
Okay, so remember, it takes 6 to 9 months in cycle for a plasma product to be made. And so we will need to stay in touch with the companies that are making plasma products for what will be occurring this fall and winter and whether they envision shortages. Could a country order a manufacturer to stop exporting their products? Yes. Yep, that can happen. Next slide, please. How does COVID-19 affect other bleeding disorders? Would anyone like to make a comment on rare factor deficiencies?
There is no association, I would say. I haven't seen any particular data regarding that, but I wouldn't expect that there should be any difference. There is only one hypothesis, but unfortunately I cannot talk about. One of the deficiency because one of the protein which is transporting the factor might be involved, but there is no data on that. I wouldn't expect any differences.
And one of the other questions, people asked about the role of factor VIII, and factor VIII is an acute phase reactant. Would anyone like to comment on what's been found in normal individuals with factor VIII?
I can do it. The levels are extremely high, over 200%. The levels are about 200 to 300%, 350%, and that's the reason I was mentioning that this situation is different from DIC. Both von Willebrand factor and factor VIII is very high. They are very high.
Cedric.
Yeah, but it means that all patients who do not have hemophilia, who have another bleeding disease, they might have very high factor VIII levels.
Yeah.
So that should not be underestimated.
Okay. Next slide. Well, I think we covered protection in a lot of detail, so I'm not sure we need to go back into that. It is in the slide set. How long should a person with hemophilia quarantine themselves? Well, go on, Flora.
No, because I was just thinking about the quarantine. What we do here, so we start at least for the patient who are symptomatic, 3 days after the stop of the symptom and completely without the fever, they start to make the first swab. And if it's negative, then they can come in. And if they are positive, we are just repeating the swab different times. The timeline was supposed to be 14 days, but unfortunately, I have to say, sometimes the viremia is and the swab is remaining positive for more than 3 to 4 weeks.
Yeah, and so that's all the more reason to use precautions such as masks, gloves when you're out in public. Asymptomatic people can transmit the disease. Pre-symptomatic people can transmit the disease, and post-symptomatic people can still shed virus for a period of time, and it's variable. So this virus is behaving differently than SARS and MERS. Each one of these is unique in terms of its biological characteristics. I'm very worried about the situation. What can I do to worry less?
Don't watch the TV and radio 24 hours on 24 hours. This is what's happening to everyone in the world. Just keep 1 hour a day and decide which are the more serious site that you can look for the data, and the rest read, make the sport, and don't really follow everything all the time.
Well, maybe, this question, what can I do to help? I think, Flora, myself, we are hematologists, we are internists. We are not COVID specialists, but I think we could, you know, give support, and the whole hemophilia team can do, and we can learn a lot, and that will provide a lot of insight for the future. So I think we need to be involved in this crisis. I think this is very important for ourselves, for our center, and for the future and our region.
Okay, thank you. All right, I'm going to go through the questions on the chat and try to scan through those. What accounts for the nearly 10% mortality rate in Italy and Spain?
Yeah, and that was what I thought. I covered that because I think the reality is not 10%. The mortality is remaining about 2%, but because our denominator is wrong and is underestimated, and that's the reason why the number of the people. So we were leaving the people with a mild symptom to stay at home and coming when the things is becoming very severe. So that means the number of the real affected were almost 3 to 4 times more.
Okay. We have greetings from people from all over the world. I won't go through those. Some of the clinical trial patients are in a lockdown. Well, the key thing here is you've got to stay in touch with your treatment center, and the treatment center needs to stay in touch with the company, the sponsor of the clinical trials. It's critical to not only ensure that continued supplies are available for patients if it's a drug that they're taking, and that any adverse events that may occur as a result of COVID-19 are recorded.
Glenn, can you go to the open questions? Because I think you're in the dismissed.
Where, I'm sorry, where are those?
The Q&A, if you press open.
Yeah, I think that's where I'm at.
Okay.
But a lot of them are repetitive.
Yeah. I think we've addressed many of them.
Yeah. From Roshni, patients who are coughing blood, can one use antifibrinolytics in addition to factor concentrates?
Antifibrinolytic, that would not be good because they are making a little bit more clot.
I would say it would depend on their status. If they are in intensive care, you know, with a very high CRP and major inflammation, I would avoid this. If they are stable with not too much inflammation, why not? That has to be individualized.
Okay. There have been a few questions about if factor is not available. I think those are largely coming from humanitarian aid countries. And what I would emphasize is the letter that Assad Hafar sent out at the beginning of the week about eliminating high-use factors such as prophylaxis, immune tolerance, and working with the humanitarian aid team at the World Federation of Hemophilia to determine what routes might be possible for getting factor into the country or other contingency plans. And it requires some significant creativity in order to get around a number of the problems, both with airports, with our entire supply circuit, including from our depots, as well as with the ministries who may not be operating at full efficiency and giving permits. So stay in touch with the humanitarian aid department and work together to figure out what to do, case by case.
There was a question about the use of convalescent plasma.
Radek, would you like to take that one? You're on mute.
Yeah. Well, what exactly was the question? I mean, there are hopes about convalescent plasma. It makes sense that using plasma from an individual who has gone through the infection and successfully and so should have developed adaptive immunity will have antibodies in the plasma, and that plasma could then be used to treat individuals, newly infected individuals. There are hopes about this approach, and the research on this is ongoing.
So maybe we have to mention that yesterday I received an email that Takeda and a few plasma-derived company, they are just doing some action, joint action regarding that. I don't know what are the timelines, and I think everybody who is positive and has antibody and is out of the viremia could donate their plasma to this project.
And Magdy, I know you're doing something in Egypt as well.
Yeah, there was one publication last week, I think, on the 27th of March from China, describing the use of convalescent plasma for 5 patients. I mean, this was like a series of case reports, and it showed some favorable outcome of using the convalescent plasma. They used very small dose, between 200 to 400 ml from convalescent COVID-19 donors. Currently, we are in Egypt planning for a randomized clinical trial where we will collect the plasma from the convalescent donors, and with the mini-pool technology, we will be able to concentrate them into hyperimmunoglobulin. And we have 2 arms, one arm for passive immunization for high-risk groups, and the other arm is for treatment. And both arms will be randomized and controlled. We are in the final touches of getting the ethical approval from the Ministry of Health, and 2 universities plus the Ministry of Health will be involved in this trial. We hope that we can get some results, but not before 3-4 months from now.
Okay. There have been a number of questions I've noticed on hydroxychloroquine. Would anybody like to comment on that drug?
Yeah, that's the kind of antiviral drug that I would say, in our experience, it wasn't bad. Still, there are a little discordant data in the literature, I would say, but our experience was not so bad, and I'm waiting for the total data getting together, because we are using it in all 3 areas of the low intensity, like my ward in internal medicine and pneumologies, and also the high intensity ward. So I would say this antiviral drug, if it's used as soon as possible, might give a good data.
I think this is the standard in Egypt, is to of the hydroxychloroquine and the Zithromax. And we can see even one of my colleagues was treated with this protocol, and he's now, he was discharged. He progressed very well.
Mm-hmm.
Cedric?
Well, you know, there are many trials ongoing for the moment everywhere on this planet. So I think that if you can include your patients with hemophilia in that trial, if there is no contraindication after open discussion with the hemophilia team, I would do that. I would do that. I think it's not a contraindication not to be in the trial because you have hemophilia, except if you have, you know, some clear contraindication.
And I would emphasize, it's just so important that we have randomized controlled clinical trials. Hydroxychloroquine has toxicities associated with it, and better to understand exactly what it can and cannot do than to rely upon anecdotal reports.
Yep.
Glenn, I see a question somewhat related to convalescent plasma, and so far that somebody's asking, can transfusion with plasma or cryo can increase the immunity? And I think it's important to touch on this. So obviously not any plasma, and we were mentioned before, convalescent plasma, so plasma from somebody who actually has recovered from the disease, but not any plasma will help. So the plasma, any plasma used in the context of bleeding treatment will not help here. And cryo would be even a less likely to help because there is not much IgG, if any, and not much immunoglobulins in cryoprecipitate. Cryoprecipitate is primarily enriched in factor VIII, von fibronectin, and a couple of other proteins, but immunoglobulins are not among them. So cryo wouldn't be helpful here.
Okay, thank you. There was a question about hemoptysis. Well, once again, this is why in situations where patients are hospitalized with more severe disease, it's important to maintain full prophylaxis, if at all possible. And then a question for me about blood donations found to have coronavirus in China. So this was from routine blood donations, asymptomatic people. 4 of them had coronavirus RNA in the samples that were taken at the time of blood donation. This wasn't preparing heat-treated products or any of that. This was just in their plasma. And so it's not known whether or not it's live virus. It's just the RNA from the virus. We don't have any evidence that it's transmitted to another patient, but it raises the question of whether or not it can be. And we will be hearing, I'm sure, much more about that. Cedric.
Glenn, Glenn, there was a nice question about telemedicine. I think this crisis is a great opportunity to value telemedicine and also increase the interaction between the Hemophilia Treatment Center and their patient. Many centers have been proactive in contacting directly their patient, and I think this is good for the future. This is something that should be perpetuated in the future.
Yeah, that could be another silver lining from this.
Yeah.
And then there was a question on increased susceptibility. Well, I think what Flora described was patients who have lung disease. Flora, I think smoking is listed as a comorbidity.
Sure. It's not the first thing, but of course, smoking is always a comorbidity for everything. It's better not to smoke anyhow. So as a list I reported, so usually when we are in the flu, time of the year, we have always some beds in the ER ready for the flu. And usually we have the people with the chronic respiratory disorders that they are arriving as a first group. And surprisingly, this year with COVID was different. They were all people that they were having diabetes, hypertension, obesity is a first group that you can see. And particularly for the younger people, so the patient between 20 to 50 years that I'm seeing now, they are most of them with the problem of obesity and with the problem of diabetes or hypertension.
Remember, any smoke that goes in your lungs ties up all of your macrophages, and that's what's required for host defense. So smoking.
They're so sick, they are never smoking. Believe me, smoking is the last chapter they can think about.
We had some questions about whether or not you can, how long immunity lasts, whether you are susceptible again. Who would like to take that?
I would love to, because I thought about that a lot. Because we were in a big delay in terms of having a good test with a high sensitivity and specificity of viremia associated with a good dosage of IgG and IgM, it was, and the shedding of the virus, understanding really what is going on. So there is a lot of research group working on that aspect and trying to understand from the IgG neutralizing and non-neutralizing antibody how that is working, and making a curve of the association between the amount of the virus and its contagiosity, and also the amount of the antibody for both group of neutralizing and not neutralizing could end up with answering this question, I would say, in the future, for how long time is this type of immunity is remaining. You remember there was in the media a big fear for the people, so it came over that China might face up with the second curve of the patient coming because that immunity was not covered. But I think that news was not really confirmed. And we do need to understand with the observation of this patient for a year to understand what is happening. And mainly what we have to remember, these patients, they are not getting cured and they're leaving you. So this disease, that's the reason why we have to keep in mind. So we have to follow them. There is a problem, it's not only with the lung, it's with the lung, with the liver, and with the heart. And we need to carry to look on them, and we have to follow them, and this is what we do, and to understand what is happening.
Flora, somebody asked about prophylactic heparin, asked you that question. I think they're wondering about prophylactic heparin with all types of COVID-19. Do you want to just set the record straight there?
You know, I want to, okay, what I'm saying, as you know, there is not yet a terminated and concluded clinical trial on that. I tell you only my personal experience, and is my personal responsibility about what I'm saying. So this is not World Federation, it's not any organization. So our experience was that we are not talking about the people with the coagulopathies. We are talking about the general population affected with COVID. There was a high association between the intensity of care and hypercoagulability. And we did notice that the normal level of heparin that we are giving as prophylaxis is not covering the risk of thrombosis in this patient. We had few cases of pulmonary emboli in patients who were on prophylaxis, and particularly those on the ventilation, and we had to increase the levels. And we have our common, table with patients at CPAP and people who are on the ventilation. I cannot share that one to you because it still is a clinical trial ongoing, and I don't want to be wrong in a procedure that I'm doing. But definitely, I think that the regular prophylaxis definitely is not enough, and we have to think about something else. And the process of clot. The clot at the beginning, if you make a prophylaxis, you are preventing well. But if the clot is formed with all the mess, the inflammatory cells, and is becoming so tough, it's difficult with a normal amount of heparin to dissolve it. And that's my conclusion.
All right, that is in patients with severe disease who are hospitalized.
Exactly. So the normal population and hemophilic do not have to use heparin. Please do not inject yourself heparin. That would be dangerous.
Okay. Another question about viral inactivation. I do want to reassure everybody that the viral inactivation techniques that are used for the plasma-derived concentrates will instantaneously kill coronavirus 2, just as they kill all other lipid-enveloped viruses. The lipid envelope is completely dissolved by these techniques, and the virus is dead.
And in addition, some products undergo nanofiltration, which will also prevent that virus from getting to the final product, since this is a relatively big virus.
The elimination. There was a question about hemophilia children. So I think across the board, there are a higher proportion of children who are asymptomatic or who get mild disease. And with each decade, the degree of serious or severe disease increases. That has been well established from Wuhan. And so children can transmit, but very few children get severe disease. Unfortunately, some do, and we have had deaths in the greater community, not necessarily the hemophilia community, but no reason why hemophilia children should be more at risk. Are any of you seeing any additional questions?
I think we have covered many. No.
I've seen a question from somebody who's wondering if they are more susceptible to COVID if they have hypertension under control, which I think we should address too.
I can talk about that. Actually, it's very important. There are two things. We did see in the cardiology ward, especially, those patients that they were having the hypertension, and that hypertension was not controlled, and it was much more difficult for the physician to control, and they have to intensify the treatment for the control of the hypertension. As you know, there is a lot of discussion about this ACE receptor and their enrollment in this disease. Now, how much is association and how much the people with the high hypertension are having the higher risk? There is a lot of discussion about that. So I would say, please control your hypertension, and try to be in the pharmacological control. But for those that they are COVID positive, this control should be a little bit more restrict, I would say. And if there is any problem, contact your physician.
We've had a number of questions about D-dimer, disseminated intravascular coagulation. Let me say two things. One is that this is rare. So it's really the D-dimer is happening in patients who are severe enough to be hospitalized. DIC may occur in intensive care unit patients who are on ventilators. And so this is not a common occurrence, as somebody asked about, in bleeding disorders or in COVID-19 infection in general. And then the second point is that simultaneously we had an ISTH symposium webinar ongoing about coagulopathy. So let's listen to that and be sure to take any messages away from that as well. We will continue to monitor that from the bleeding disorders perspective, and we'll update as needed our guidance.
But just one point, which I think is really a wrong message. This is not a DIC. Even in the high intensity, there is no consumption of the factor, there is no increase of the PT and APTT, and only in a very few cases where there is a different type of infection. Most of the patients have a high number of the platelet, they have high level of D-dimer, and the normal level of the PT and APT. This is a different coagulopathy, and we need to learn about that.
Okay, thank you, Flora. All right, I think we're going to wrap up. We're at the end of our second hour. I want to thank all of you who have continued to stay on the line, and hope that this has been useful. I also would very much like to thank our panelists who have put a lot of time and effort into putting this webinar together, along with Donna and Mace from the WFH, who have been able to organize all of this for us. We'll do this again as needed, and in the meantime, I would emphasize perhaps an unpopular comment: stay away from social media sites where you can get a lot of false information. Stick with the sites that are giving you the facts, and those sites are updated on a regular basis, sometimes multiple times a week. And so that is the best source of accurate information. Any final comments from our panelists?
Good luck.
Thank you. That was great.
Thank you.
Thank you. Stay safe.
All right, everyone. Thank you all for your attention.
Thank
Bye-bye.
you.
Thanks, everyone.
Bye-bye.
Bye.